sessions, but this time we have entered into an understanding with the Clarinet web platform, so that you can hold our class in their platform. I hope this will be more easier for us to conduct the classes. So today we'll have a long case discussion on gastric outlet obstruction due to peptic ulcer disease. Dr. Anuradha Maji, who is a third-year junior resident at IPGM, responsible to present the case, and Professor Utpal De, who is a professor of surgery at NRS Medical College, will moderate this session. Dr. Anuradha, you can share your screen and start presenting. Welcome, Dr. Bhabin Patel. Anuradha, you can share your screen. Screen share is allowed.
So, they are moderating it.
Yep.
So screen share is allowed. Dr. Maji can share her screen.
Anuradha, open the presentation. Anuradha, you're muted. You unmute. Anuradha, you have to unmute and share your screen. Anuradha, you could open the presentation. तुम्हारे पास है नहीं? Anuradha, you can talk to Deblina. Any problem? Anuradha? Deblina, she's saying she cannot share the screen. What's the problem?
So everyone has allowed to share their screen. So Dr. Maji, if you could reply me, I will help you. Hello.
She's on the phone with my boy.
Okay.
So she's not able to hear. There is some audio problem.
Actually, she is not listening our voice.
Okay, then maybe she needs to connect the audio with some headphone or anything. Allow the audio. Because her audio is connected, I can see.
Yeah. Oh, yes, Anuradha did not come in platform. Eh?
No, sir. But it is same like normal.
She is asking that she should change her audio connection. Anuradha, you log off and join again.
Mahalla asked him to speak over the microphone, then we can understand what problem she is having.
Anuradha, You come closer to microphone. Anuradha, you can hear us? Anuradha? She is not listening her voice. What is the problem?
So one signal is from
So skin is shared.
no, sir. No, sir.
Your skin shade. Dr. Dey, is the screen visible?
Yeah, yeah.
Achha. Anuradha, you can't hear us. What is the problem?
Sir, is it possible to join from other device from Dr. Maji?
She is not listening. That's the problem. Ask her to join from mobile or whatever. Anuradha, you're in? No. The whole slides are done. Na?
It's a slide. Sir.
तो क्या करूं? You
Mahunda, can someone else just present because we are going to have a discussion in any. Mahunda, please unmute yourself.
Dr. Dey, I asked Dr. Milin to present the case as he's already prepared, and you can keep on discussing.
Yeah, yeah, yeah.
Okay. Milin, please.
Let kindly go on to a full screen mode. Huh?
Sir, is the full screen not visible, sir?
No, no, the screen is visible, but the slide snippets are also visible on the left hand side. So just shift on to the full screen mode.
Okay, sir. Just
Go down, go down. Yeah, yeah.
is it okay?
Yes.
It's
Yeah.
okay.
Good morning, sir. Good morning, respected faculty members. Today there will be a case presentation on gastric outlet obstruction following peptic ulcer disease. The patient, Mr. X, 40 years male, a manual laborer by occupation and resident of Havana, came with the chief complaints of pain abdomen for the past 2 years and vomiting for the past 5 months. The patient was apparently well 2 years ago when he started having occasional pain in the mid upper abdomen, which was moderate intensity dull aching. Intensity of pain started increasing following prolonged periods of fasting, usually lasted for a few hours and relieved partially with food intake and antacids. It was associated with heartburn, sour taste in mouth. These symptoms usually lasted 2 to 3 months and subsided with medication use and recurred after every few months. There is no history of radiation, or there is no history of radiation of pain. For the past 5 months, patients started experiencing occasional copious vomiting following heavy meals. Vomiting occurred around 10 to 12 hours after food intake. It was projectile and non-bilious in nature and contained undigested food particles. No history of blood in vomitus. For past 1 month, patient experiences vomiting almost after every meal, around 2 to 3 times per day, 4 to 6 hours after food intake. He often experiences a ball rolling movement in upper abdomen following food intake, which subsides after vomiting for the past 5 months. No history of jaundice, no history of blood in stools. Past history. No history of diabetes, mellitus, hypertension, or any other comorbidities. No history of allergies or chronic medication use. History of occasional pain medication and antacid use present. History of open appendicectomy 15 years ago. No history of TB or contact with TB patients. Personal history. He is married for 10 years. He takes mixed diet. Appetite is preserved. Patient complains of constipation for the past 2 months. Frequency of micturition is reduced. Sleep habits are within normal limits. There is history of loss of weight, which he is not able to quantify. There is history of alcohol binge drinking occasionally for more than 15 years. There is history of tobacco smoking around 1 to 2 BDs per day for more than 10 years. Family history, no history of similar complaints in family. His parents are alive and healthy. He lives with a wife and 2 children who are healthy. Treatment history, he underwent an abdominal ultrasound and upper GI endoscopy 2 weeks before admission. He has been taking oral medications regularly for the past 2 months to relieve pain, abdominal acidity.
Okay. So these are the points which were discussed in the history. Now, Milind, shall I ask you a question or shall I?
Yes. We can discuss because there are some lacunae in the history part. Yeah.
So from the history itself, if you see, go to the chief complaints.
Yes, sir.
So chief complaints are, you see, he has written pain abdomen for the past 2 years and vomiting for the past 5 months. So that is what she has stated in her history. Now, apparently, this pain abdomen is characterized. She has characterized it, but this pain abdomen, I feel, is a sequel to that vomiting. So I feel that the characterization of the pain should be a bit more elaborated as far as the pain is concerned. She has said that it is a moderate intensity dull aching. Now, if we feel about or if we take into consideration a benign disease, I don't think that this moderate intensity dull aching pain fits aptly into this scenario, because though we know that most of these patients nowadays it's very rare to find patients with peptic ulcer disease in the surgical scenario. So most of them, they go into the medical field or in the medicine domain. But then when we think about a moderate intensity dull aching pain since 2 years, definitely we tend to, this type of pain tends to be more in favor of a malignant disease. So pain, actually, if you look at these patients, most of these patients, they usually present with vomiting. So that is important. They usually do not complain more of a pain. Means what they do come with is the repeated history of vomiting, and if you inquire, they will say that he had a history of acid peptic disorder. So that is what they usually say. But pain as such is not a very much significant complaint in this patient. So that is what I feel. Now, though she has described it that it starts following a prolonged period of fasting, lasts for a few hours, relieved by intake of food, though they go in favor of a duodenal ulcer. But still, I feel that these patients do rarely complain of pain. Means most of them, they complain of vomiting, they complain of weight loss, they complain of weakness, and if we inquire further, then they usually give a history of diurnal variation of pain since the last 2 years. So, though that is why I say that though it is a sequel of this thing, but I think this characterization of pain should be a bit more means it should be defined in a different type than what she has described here. So that is my take from the history of pain. Otherwise, what she has mentioned about use of medications which subsides with pain and everything, that is fine. So I do not have any issues regarding that. And another thing which I have got some objection is there is no history of radiation of pain. So what is this means I do not get what she is talking about radiation of pain. Because if you see characteristically in patients with gastric outlet obstruction, radiation of pain actually signifies something else. So it's more of an extrinsic obstruction than an intrinsic obstruction. So that is also one take from my history of present illness. So these are the two issues which I feel should be taken into account. Because if we look at the history of this gastric outlet obstruction, it's usually presents in three scenarios. It may be an acute obstruction, it may be a episodic obstruction, or it may be a chronic indolent obstruction. So means for acute obstructions, usually we have all these peptic ulcers, diseases following, means not the ones which are usually complicated with strictures, but the acute ones. And there are other causes of acute obstructions also. So the history of pain abdomen is very important. That is what I feel from this history of present illness.
And Dr. Day, what I feel is patients who are having peptic ulcer disease, 2 years is a short period to develop a chronic cicatrization leading to stenosis. That is one. And second is the classic history. If the patient has got a classic history of pain, which is like this, and he has got repeated episodes, that means there is a definite periodicity of pain. That is a point against malignancy. Patient who has got a definite periodicity of pain over the period of 2, 3, 4 years, these are more likely to be more of a benign peptic ulcer disease. And second thing is, in a patient like this, don't take the appetite, weight loss, everything to personal history. These all comes in the group of history of present illness, because they are all important symptoms. If you now talk of this patient, you are presenting with the pain, and then you have missed another important symptom, which most of the patient complains. Nobody starts with sudden onset of vomiting in a patient who has got chronic ulcer causing stenosis. Most of the patient has got sensation of fullness after meals. Patient takes a breakfast and then towards evening he is feeling full. He does not take a dinner properly, and then gradually vomiting comes up. And you have described the vomiting in proper manner, that initially it was towards the evening, and then it started coming out every feed. That is true, but most of the patient has got a symptom of sensation of fullness after meals. And then bring everything, the bowel habit, the bladder habit, the patient has got diminution of urine, everything should come to history of present illness, because you have to justify the diagnosis taking points from history. If you say this patient, this 45-year gentleman has got a preserved appetite and he has got weight loss, that is a point in favor of a benign disease. Patient has got a carcinoma of stomach, has got a significant symptom of anorexia, that goes in favor of a malignancy. So bring everything. Anuradha, can you hear us?
Good morning, sir. Sir,
Good
I
morning.
wasn't able
Okay.
to hear properly. Now I
Okay.
can hear.
So Milind will share the screen. We are discussing the history part.
Yes, sir. Thank you, sir.
What I'm saying is, you have taken most of this history to the personal history.
Yes, sir.
Okay, but this is a GI case. This is a GI case. It should bring all these symptoms to the history of present illness. And how do you explain that patient has got this pain which is coming episodically? What is the character of pain who has got a benign peptic ulcer disease? Why the pain get relieved and again he has got relapse of pain after 2, 3, 4, or 6 months?
If it is a duodenal ulcer pain, Usually when the patient is in empty stomach, when the pyloric.
Now I'm asking about the periodicity. How do you explain the periodicity of pain? That patient has got pain for 2-3 months and then he's relieved.
The acid. The periodicity can be explained because he also had a history of taking chronic medications.
Yes, so what
Like he
happens?
was taking antacids, he was taking.
So what happens to these
So whenever
ulcers?
the ulcers get healed sometimes.
Yes. So
and
that
they
is the
lead to
explanation for
cicatrization.
periodicity. These ulcers
Yes.
may heal with antacid, and sometimes these ulcers may heal as a part of natural history of the disease. So
Yes, sir.
this explanation for patient having pain-free period, and these are more predominant. This periodicity is more predominant in duodenal ulcer disease rather than gastric ulcer disease. Gastric ulcer patient may have periodicity, but this periodicity is more marked in patient has got chronic duodenal ulcer. So these are important. What Dr. Dev was trying to say is the way you presented the history, it may go to even a malignancy unless you have other points to refute, like his appetite is preserved. Weight loss will be there because patient is vomiting. So he will have definitely have weight loss. Okay. So you present the, yes, Dr. Dev.
Yes, Anuradha, what I feel is, can you tell me the different presentations of patient with gastric outlet obstruction? I just had a discussion regarding that. So, can you tell me the different ways in which a patient can present?
The patient, a case of gastric outlet obstruction usually will be presenting with vomiting, current episode after
I'm unable to.
meal.
Your audio,
Initially, the
you
patient
keep the
will.
video off. Anuradha, keep the video off and just keep on speaking.
Okay,
Yeah.
sir. Patient will have initially the patient will have stomach prolonged after a prolonged period of time after food intake. We last hours,
Anuradha, I'm
which
not
will
able.
occur around 10 to 12 hours of undigested food coming in vomitus, and
Anuradha,
following
your audio is
which.
not clear. Go to a place with a little better internet connectivity.
Okay, I think without wasting time, one thing I also need to state here is that regarding food intake. Now, initially, what happens is there is a characteristic feature as far as food intake is concerned. Now, initially, if you see these patients, they will have they can take both solids and liquids foods equally. Now, as time
Yes, sir.
progresses, what happens is the patient can take liquids easily, but then taking solid food causes problem. Okay, so what I
Yes,
asked you actually, these kind of patients with gastric outlet obstruction, if we don't take into consideration peptic ulcer disease, as I said, they can present in three ways. Means it can be an acute obstruction, it may be an episodic or recurrent obstruction, or it may be an indolent or chronic obstruction. Okay, so can you tell me some causes of acute obstruction?
Sir, acute gastric outlet obstruction.
Yeah. Don't think about peptic ulcer disease. So think about other causes which might cause acute obstruction.
Okay, acute causes of gastrointestinal obstruction can be in the form of
Not gastric.
volvulus
I'm
or
asking
intussusception.
No. I'm asking about gastric outlet obstruction, acute. Okay.
Okay.
There may be suppose there is an acute duodenal ulcer, right? So there might be edema. So that might cause an acute obstruction. Number
Okay.
one.
Okay.
Number two, do you know what is Beveridge syndrome? Have you heard of it?
What, sir?
Beveridge syndrome, BEVERETS.
No, sir, I couldn't remember.
Here what happens is there is a gastroduodenal fistula, and if there is a large stone that might get impacted there, so that might cause acute obstruction, right?
Okay.
There may be food bolus which gets obstructed, right? Volvulus, you have rightly pointed out. Yeah, that is also one cause of acute obstruction. Now, can you tell me some causes of episodic obstruction? Means intermittent obstruction. I'll give you the answer. Sometimes what happens, there are duodenal polyps which are there. So sometimes it obstructs, sometimes it does not obstruct. Okay, so that is one. And for chronic obstructions, you have so many causes. And for chronic obstructions, as you have rightly described, so it occurs over a period of time, and slowly the symptoms they usually come into play. Okay, so let us move to the next slide. Okay, you said that for the past 5 months, she is experiencing occasional copious vomiting following heavy meal. And can you describe the characteristic vomiting pattern in patients with gastric outlet obstruction due to peptic ulcer?
So the characteristic
There are
pattern will be a
there are certain adjectives which you need to say and which usually describes or fits into the category of gastric outlet obstruction. Yes.
it will be projectile in nature.
Okay.
Usually it will be an effortless vomiting, which will be precipitated after like during the emptying phase of the
Okay.
stomach, and it will be non-bilious in nature since the
Okay.
duodenal or bilious contents are not present. And
Okay.
usually the vomitus will be containing undigested or food bolus.
Okay. Anything else?
And
Differentiated from gastric means malignancies. Patient will feel hungry after vomiting, right? And the
yes, sir.
vomitus will be offensive in smell. Okay. So you said it will be projectile, and then you said it will be effortless. What does it mean?
It means that the patient will not, the nausea will not be preceded by the vomiting phase, and the vomiting will be violent vomiting, which is the patient will have to put less effort on the vomiting for to contract the diaphragm and get the vomitus out, rather than it will be a violent vomiting where the vomitus would not land near the patient. So that is the kind of projectile vomiting he's going to have.
Okay, so here what happens is there is a there are two vomiters in cases of gastric outlet obstruction. Maybe if you categorize it, it may be divided into two types. One is mechanical, the other is non-mechanical. Right? So you have these characteristic features when there is a mechanical obstruction. Right? Mechanical obstruction means, I mean, gastric outlet obstruction due to pyloric stenosis or any obstruction in the pylorus. Okay. Now, what happens in cases of non-mechanical obstruction? What kind of vomiting do you find?
So in non-mechanical obstruction, usually the vomiting is precipitated by the triggering of the chemoreceptor trigger zone or any enteric nervous system. In that case, the patient will have preceding nausea. And apart from that, depending upon, initially the patient will have food particles which are higher up in the gastrointestinal system, but then the bilious content would also come since they
Means in non-mechanical obstruction, what happens is the stomach is usually dilated, right? So here it will be more of a regurgitation type of a vomiting than a projectile type of vomiting, right? And one thing else is the patient means it's just like an overflow. Suppose you have a dam and the water is there, so it's overflowing. But there it's like opening the gates and then a gush of thing comes in. So here the stomach will be full even after the patient has vomited. Okay. Okay. Now, next you have said that he often experiences a ball rolling movement in the upper abdomen following food intake. Can you just elaborate on this?
The patient gave a history that he often feels there's a movement in the upper abdomen, just like a ball rolling, but then he was not able to specify the direction of the movement. He just said that he feels some kind of movement in the upper abdomen, and which aggravates with food intake. And after vomiting, that usually subsides.
So do you need to further clarify this rolling movement?
Yes, sir. I have
to the other side, or is it from left to right, right to left? What happens?
Sir, I have clarified this in the examination, where I have asked the patient to take gulps of water before examination.
No,
And
that
I
is
have seen the visible gastric peristalsis
that
from left to right.
that is in the examination section. But usually the patients they come.
Yes, sir.
Can you tell me the different types of movements that are usually found in patients in the abdomen in patients means in with abdominal pathology with other abdominal?
Upper abdomen. In the upper abdomen, if
Not
the
in the
transverse
upper
colon
abdomen.
is also.
It's not
Yes,
in the
sir.
upper abdomen. Throughout the
Okay.
abdomen, what are the
Okay,
type
sir.
of movements which the patient might complain of?
The patient might complain of peristalsis, which can be due to, if it is right to left, there can be a obstruction in the splenic flexure, leading to obstruction in the transverse colon. So that movement will be from right to left.
Okay.
There can be obstruction in the small bowel, which will lead to stepladder pattern of visible peristalsis.
Okay.
And if there is any obstruction in the cecum or the ascending colon, then we might find peristalsis in the right side,
No.
And
in
what
the
about
right flank.
Fecal obstruction will mimic small bowel obstruction.
so
You cannot say it's a large bowel obstruction. Fecal obstruction will mimic small bowel obstruction. You'll have series of movements coming from upper abdomen to mid and lower abdomen. It's like that
Yes,
only.
sir. Yes,
that means and what is the kind of movement that you find in patients with sigmoid volvulus?
In sigmoid volvulus, usually there won't be the volvulus part will be hugely dilated. So
Volvulus part will not be hugely dilated. It will be hugely dilated. That is why it is
yes,
volvulus.
sir. So
What
actually,
happens is characteristic feature is here in the upper abdomen you have a movement which starts from left to right when there is an obstruction in the pylorus, right? You have
yes,
rightly pointed out. Small intestine, yeah, step ladder pattern movement you find, or sometimes in one of the recent advances I've seen, they say it's a gola type of a movement. That is what is exactly displayed. And then from right to left, you have obstruction in the splenic flexure because of transverse flow. Now, the characteristic feature in volvulus is it you do not find an obstruction which is there in the upper abdomen. So it's characteristic in the lower abdomen. So if you have, means it's very rarely visible if the patient comes early, you can see. You'll find the distension occurring from the pelvis itself. And it will be, if it is not so chronic, then you will find it mostly on the left side of the abdomen. Right.
Okay, we can pass on to the examination.
Yeah.
One other.
yes, sir.
Come to the examination. Yes.
In examination, in general survey, the patient has been examined in the decubitus position. He was conscious, alert, and he was cooperative. And his vitals were examined. His pulse was 96 per minute, good volume, regular. His blood pressure was 116 by 80 millimeters of mercury. His respiratory rate was 20 per minute. He was afebrile to touch. His tongue was dry and skin turgor was reduced, suggesting dehydration. And he was moderately built but poorly nourished. He was asthenic. His BMI was calculated to be 20.8 kg per meter square. And his pallor was present, but there was no lymphadenopathy or pedal or sacral edema. I have calculated the performance status, which is ECOG 1 and Karnofsky scale 80. On local examination of the abdomen, on inspection, the abdomen is scaphoid with visible fullness in the upper abdomen. The umbilicus is central and normally inverted. And there is an operative scar in the right iliac region, probably a McBurney incision scar. And a visible peristalsis in the upper abdomen in the left hypochondriac, epigastric, right hypochondriac, and the umbilical region, which is moving from the left to right direction. The hernial sites are free and external genitalia examination is within normal limits. On palpation, there is no local rise of temperature over the abdomen. The abdomen is soft and non-tender. There is no guarding or rigidity present. There is no hepatosplenomegaly. Hernial sites are free and external genitalia is within normal limits. On auscultopercussion, there is no shifting dullness. There is the distended stomach can be is palpable and can be delineated by auscultopercussion in the epigastrium, left and right hypochondrium and umbilical region, and normal peristaltic sounds are heard in rest of the abdomen. I have done a digital rectal examination of this patient, and there is normal anal tone and mucosa and normal stool staining present. Other system examinations are within normal limits.
Okay, wait. Uh, uh, what in auscultopercussion you have mentioned? Go to that slide. Okay, let us come from the general survey itself. Yeah. So you said that the patient has got a pulse of 96 per minute, good volume, and you have said tongue is dry, skin temperature is reduced.
Yes, sir.
So what does all these signify?
The patient is having dehydration, but then still the patient is not in a state of shock. So like, even though he still needs intravenous fluid and
Okay, so that these indicate that the patient is dehydrated.
yes, sir.
Now, you said that the patient has got pallor. Can you tell me the cause of pallor?
The pallor might be due to chronic malnutrition, due to reduced intake of food and repeated vomiting.
Okay, it could be due to the chronic episodes of bleeding from this peptic ulcer disease also, right?
Yes, sir.
Okay. Okay, go to this thing, examination of the abdomen. So you said abdomen is scaphoid with visible fullness in the upper abdomen. So what do you mean by fullness in the upper abdomen? Which part of the abdomen are full?
Sir, the visible fullness might be just the
Yeah.
distended stomach,
No,
which
no,
is
I'm not asking you the cause. Tell me which part of the abdomen.
Regions in the abdomen.
the regions, the epigastric, the part of the right and left hypochondriac, and the umbilical region.
Of these four regions that you have mentioned, which is more important? Because if you look
Yes.
left and the right hypochondrium and the epigastrium, these are very small areas. So the umbilical fullness or fullness of the umbilical area, so that is
Yes.
of more concern than fullness in the other areas. What do you mean by scaphoid abdomen?
Scaphoid abdomen is the contour of the abdomen. If we take a scale and then place over the abdomen, usually the xiphoid process, the pubic symphysis and the umbilicus should be in a straight line. But when the umbilicus is the abdomen is concave, where the umbilicus is at a lower level compared to the xiphoid and the pubic symphysis, that is
It's more like a
that is-
Boeing. You mean Boeing?
Yes, sir, more like a Boeing.
Okay, so that is known as the xiphopubic line, right? So normally umbilicus lies on the line. So it might be below or it might be above or it might be at the level. It lies slightly below actually. When it is at the level of the xiphopubic line, we say that the abdomen is full. Now, if it lies much below, then we say it's scaphoid. And if it lies above, then we say that the abdomen is distended. Now, can you tell me the different types of abdominal distension?
Sir,
So abdominal distension can be of two types. One is it can have a boiled egg appearance, means where you find the whole of the abdomen distended with the flanks full. You get my point? Or it could be a post-egg appearance. Post-egg appearance means you have a localized collection of fluid in the abdomen, but the flanks are not full. So these are the two different types of abdominal fullness, that means abdominal distension, that we usually find. Okay. Okay. Visible. Okay, you have mentioned about visible peristalsis. You have mentioned about hernial sites. That's very good because that needs to be examined. Go to the palpation section. Okay. Now, did you mention about succussion splash?
Sir, I have not performed a succussion splash on this patient, sir.
Why?
He was not very comfortable, so I did not examine, so I have not mentioned it, sir.
What do you mean by you are not very comfortable?
Uh, mm,
Is it means apart from ausculto percussion? So ausculto percussion is not a very sensitive sign for this thing, gastric outlet obstruction, right?
yes,
So
sir.
there can be errors in that. But if you look at the literature or if you look in the books, succussion splash is one of these signs which are quite important, or it is of vital importance in patients with gastric outlet obstruction. So I
Okay, sir.
feel that succussion splash should be mentioned. Okay. So
Okay.
now you
And
said
and Anuradha, you said you ask the patient to drink a little amount of water. Keep in mind that if you want to demonstrate succussion splash, you should not ask the patient to drink. And patient having a already a distended stomach showing visible peristalsis, you need not ask the patient to drink water. It's not necessary. When you already have the fullness being seen, you can easily appreciate the peristaltic wave. Okay, if the situations where the stomach is not full, but you want to stimulate peristalsis, in that case, you can ask the patient to drink some amount of water. Otherwise,
Yes, sir.
drinking water is not required. And keep in mind that succussion splash has to be demonstrated first, and then you can ask the patient to drink water.
exactly.
Yes, sir.
Okay, go to your professional diagnosis.
Summarize
Sir,
quickly.
after the summary, I have the provisional diagnosis.
Yeah.
Please summarize.
Sir, I'll summarize the case. Sir, Mixer X, 40 years of age, male patient, presented with moderate intensity dull aching pain in the mid upper abdomen for the past 2 years, which was more during empty stomach and relieved partially with food intake. He complained of heartburn and acid taste in mouth for the past 2 years. And he also complained of projectile non-bilious vomiting following food intake for the past 5 years. Vomiters contained food taken 4 to 6 hours earlier. He often experienced a sensation of ball rolling movement in the upper abdomen following food intake, which subsided after vomiting. And he had a history of occasional binge drinking for the past 10 years and regular smoking for 10 years. And he had a history of appendectomy 15 years ago. On examination, on general survey, the patient is moderately built but asthenic. He is dehydrated. There is pallor and abdomen is scaphoid with a fullness in the upper abdomen. Visible peristalsis seen in upper abdomen moving from left to right. And there's a distended stomach in the epigastrium, left and right hypochondrium and umbilical region, which is delineated by auscultopercussion. And there's a McBurney incision scar in the right iliac region. And other system examinations are within normal limits. So coming to the diagnosis, this is a case of gastric outlet obstruction due to probably a chronic duodenal ulcer.
Chronic duodenal ulcer. Okay. Now, can you tell me why you say it's due to chronic duodenal ulcer?
Sir, but clinically, by history, as patient used to have abdominal pain, epigastric pain in empty stomach, and it used to relieved after food intake, which is characteristic of a duodenal ulcer, where the patient has a multiple. He prefers it taking frequent meals so that he's out of pain
So
most
there's
of
a
the time.
characteristic pattern, right? From
Yes,
the
sir.
so there's a characteristic pattern of pain, and following which he developed all these symptoms. Okay.
Yes, sir.
You said that in the general survey, the patient is dehydrated and the skin texture is lost, and you have all the signs of dehydration, right?
Yes, sir.
Can you tell me the metabolic changes that usually occur in these patients? Just tell me
Usually after
the,
recurrent vomiting
tell me
and dehydration.
what
Yeah.
happens. You tell me the metabolic changes.
Yes, sir.
What elaborate?
They will have hyponatremia, hypokalemia, hypochloremic, metabolic acidosis with
Metabolic
paradoxical
alkalosis,
aciduria,
No, no,
not
no.
acidosis.
metabolic alkalosis with paradoxical aciduria, which will set in later. And they can also have hypocalcemia and hypomagnesemia along with.
Right. I first you said hyponatremia, right? Initially,
Yes,
what
sir.
happens is there is hyponatremia, but later it gets corrected. So hyponatremia, I think if you want to say, you have to say that initially it is present, but later it is corrected. Hypochloremia, hypokalemia, hypocalcemia, hypomagnesemia. right? And then you have metabolic alkalosis. But you need to follow, if I tell you, ask you to arrange it in sequence in how it occurs, can you arrange it?
Sir,
What
initially
happens at
there
the
will be
beginning? You see, patient is vomiting. What
Yes, sir.
patient is losing?
Patient
He
is
is losing
losing
what?
H plus and Cl
Yeah,
chloride
and water. He
and
is
water.
losing water and H ion and chloride ion. That is initial insult.
Yes,
What
sir.
happens in the body following this?
To correct that, renal in the kidneys, the H plus will be saved and the potassium will be lost. So the sodium will also be lost. So
How H plus is preserved?
H plus
What
is
happens?
preserved.
What happens in the
Mm.
kidney at the first onset of this vomiting and dehydration?
ADH will be released, so that will act on the kidneys to preserve the water. So
And
and apart from that, RAS system also gets activated. That will lead to
That will lead to what?
kidney will lose H ion or kidney will try to lose bicarbonate ion at the beginning?
at the beginning, the kidney will try to lose bicarbonate ion.
Yes. And
Because
how is
H
the
plus-
bicarbonate lost? What it takes
Uh,
along with?
It will take sodium along with it.
Yes.
Sodium
So that
and
is
sodium.
what happens. Initially, it is hydrogen and chloride ion. Subsequently, as the kidney tries to compensate, it loses more sodium bicarbonate. So body senses sodium deficit. What happens after that?
After that, to preserve the sodium, now the potassium ions are being lost in the kidneys.
And
So,
what happens? Aldosterone response.
Yes,
There
sir.
is aldosterone response. And
Yes, sir.
aldosterone conserves what?
Sodium,
Try to conserve sodium in exchange for
potassium,
and
uh,
hydrogen ion. That is
and
what you
hydrogen.
said as paradoxical aciduria. That is
Yes.
how paradoxical aciduria comes.
Yes, sir.
So this is very important because you need to know these metabolic changes. These metabolic changes are often asked in the exams, right? So
Yes, sir.
might be well done. Okay. So this is your diagnosis, right? So how will you now prove?
Now, I will ask one thing. If you said patient is chronic alcoholic for 10 years, is there a differential diagnosis?
The patient can have acute gastritis, acute pancreatitis due to chronic alcoholism.
Not acute pancreatitis. 10 years he is alcoholic. Now he's having
Chronic
symptom for 2 years. I cannot put this only as acute pancreatitis.
Can you think of
And chronic pancreatitis cause identical presentation?
Yes, sir.
Yes, very close.
Yes.
You have to keep in mind.
that fits to your history also because in one point you have said that there is radiation of pain to the back.
Sir, actually, I said there is no radiation of
No
pain
radiation.
because
That
I
is one
wanted
point.
to.
Yes, yes. No radiation. Okay,
Different.
that the other points. But you should always keep in mind, patient who is chronic alcoholic, who is a smoker, chronic pancreatitis is one of the important possible differential diagnoses because you are the patient who can present with chronic pain and an outlet obstruction also. Chronic pancreatitis patient may also have gastric outlet obstruction. Okay, fine. Then management. Yes, Dr. Dey.
Yeah, tell me the investigations what you would like or how will you arrive at your diagnosis?
Sir, first of all, I'll resuscitate the patient and following which
How will you
admit the patient, resuscitate the patient, and then we will
How will
go
you
for upper
resuscitate?
GI endoscopy.
How? What is the resuscitation?
No, we'll wide bore IV access and normal saline. According to the first, we'll give 1 liter of fluid challenge and assess for the signs of dehydration.
Suppose a
And
patient comes to you, these patients usually come to the OPD, right?
yes, sir.
How
We
will
have to
you-
admit the patient, sir.
So that is very important. So for all other benign causes, you need not admit those patients. But with patients with gastric outlet obstruction, to resuscitate, you need to admit the patient.
Yes, sir.
Okay. Yes.
And you must say that you need a preparation for subjecting this patient to upper GI endoscopy. You cannot
Yes,
just send the patient next morning to the endoscopic suite for a endoscopy. Why
So
you
we
need
have to
to
do
prepare?
gastric lavage. We have to do a nasogastric, put a nasogastric tube and do a gastric lavage. And following which we have to send the patient for upper GI endoscopy.
How many days
And
after admission will you send?
yes, sir.
How many days after admission will you send for this endoscopy?
Sir, after the patient has been stabilized and after 2 to 3 days, sir, after like the gastric mucosal edema has been subsided, only then we can send the patient for endoscopy.
Means in other words, can you tell me the signs of optimization? When do you feel that the patient is adequately optimized and then you can send the patient for upper GI endoscopy?
Sir, his
What are the
fine.
parameters? You will see that patient is getting resuscitated. You say resuscitation. What are
Yes,
the
sir. First of
parameters you
all,
look for?
his vitals will be stable. We have to check the fluid and electrolytes. So he will have all the fluid and electrolytes coming to the normal values. And
And clinically, you said patient has loss of skin
the signs
turgor.
of, yes, the signs of
So
dehydration
tongue
will be
should become
absent.
moist, skin turgor should come back, his urine output should be coming to normal. So you have a way of clinical assessment and then go for biochemical. Yes.
And for endoscopy, do you need to take any precautions, or you need to tell the endoscopist, or where you often find the endoscopist asking for some precautions? So is there any need for precaution? And if so,
We have to state the diagnosis of the patient that he might be having peptic ulcer. So due to which there's a high chance that during endoscopy there might be a gastric perforation.
no,
So
apart from
No.
perforation, before perforation, while introduction of the endoscope, can something happen to these patients?
um,
So the
But
patient,
stomach is already full. Huh? Stomach is
Yes.
full. So
Yes, sir.
these patients, unless you prepare well, there is risk of aspiration.
Yes, sir.
in our times, our teachers used to say that we need to resuscitate these patients for at least a minimum of 7 days, right? Before you set these patients for endoscopy, because there is every chance of aspiration. Okay, endoscopy. So endoscopy is one of the modes of investigation done in these patients. Okay, what characteristic thing in endoscopy is suggestive of gastric outlet obstruction?
The stomach will be hugely dilated and the scope will not be negotiated beyond the pylorus. It would not negotiate through the pyloric channel.
That depends on degree of stenosis. We have tried to understand.
Yes.
It's not a blank statement. You cannot put the scope into the pylorus. That depends on the degree of stenosis. So either you try to negotiate, you may be able, or if it's a tight stenosis, you may not negotiate.
So what you will find is actually first after you introduce the scope, you will find a huge distended stomach. Rugosities will be less compared to
Yes,
a
sir.
normal stomach. Then you look at the pylorus. So there may be various shapes of the pylorus, starting from a golf hole pylorus to a partially narrowed pylorus to a scarred pylorus or deformed pylorus.
Yes, sir.
Right. So you see, we say it's a gastric outlet obstruction. So actually, if you look at this, this is a misnomer because gastric outlet does not have anything to do with this obstruction. The obstruction actually occurs in the pipe. Okay. Okay. So endoscopy, need to look at the pylorus, and we don't just go on pushing it through into the duodenum. Okay. So
Yes,
that
sir.
is in endoscopy what we find. Okay. Anything else you would like to do?
Would you find do you expect to find a active ulcer in these patients? Is it common to find active ulcer in these patients?
No, because
Usually not, because once you have the pyloric stenosis coming up, it is likely that the ulcer has healed and it has got fibrosis. It is unlikely to have an active ulcer. But what else you look for? While doing endoscopy, now endoscopies will do some more test, even if it's a benign disease.
sir, we can see Barrett esophagus in this patient.
Barrett
And-
esophagus.
Apart from that, okay, Barrett's
And-
esophagus is once we are entering, isn't it? So
Yes, sir.
because that will have a different kind of complaints. Okay, so
That is done by all endoscopy report. You'll find they send a small slide with the patient.
A rapid urease test can also be done in this
Why?
patient.
Not also be
Uh,
done. It is to be done.
Yes, sir. Because H. pylori infection, it is endemic to India, so it is very
And it is
common to
important.
find.
If you document patient has got a established H. pylori infection, you have to treat it.
Yes, sir.
Because that is one of the important detail factor, and that is one important factor for recurrence.
Yes, sir.
Okay, so you have to, the one is urease test. How else you can confirm H. pylori infection apart from this urease test,
Via the breath
breath test?
breath
What
test,
else?
yes, sir.
You are doing endoscopy. What else?
Apart from that, pH monitoring 20.
No.
where does this H. pylori, where does it lie?
In the gastric mucosa. In
So?
ulcer.
So you can take a biopsy.
Yes.
You can take a biopsy on the gastric mucosa. You can demonstrate the organism in
Yes,
biopsy
yes.
specimen. Okay.
Yes.
Any other indirect test? Any blood test?
Mm,
Any
uh,
blood test?
we
This is
can
described.
do ELISA
Yes. ELISA for an
for
antibody to H. pylori
H.
infection.
pylori. Yes, sir.
ELISA for antibody to H. pylori infection. So these are all indirect tests. So that has to be done. In a patient who has got a peptic ulcer disease, he should exclude associated H. pylori infection.
Yes, sir.
Okay, now we know that this patient is having a. You also need to know something about the dye test which we used to do before, right? So because I'm not going into the details of it, but you should know actually the timing as to how much time you need to the dye stays in the stomach. When can you diagnose it, or how do you diagnose it? What are the signs which are present? So that also needs to be known. Though nowadays it's rarely done, but then sometimes you might find endoscopies are not available in the periphery, so you need to do that. Okay. Now your patient is now prepared for, you have optimized your patient. Your patient is prepared. Now tell me, how will you treat this? Treat your patient.
Will this patient require surgery at all, Anuradha? Or you can treat him conservatively?
No, we should not treat anymore conservatively because he has already developed a complication of duodenal ulcer.
Yeah.
So we have to go for surgery. The usual surgery which can be done in this patient is truncal vagotomy and gastrojejunostomy, which is a drainage procedure. And apart from that, highly selective vagotomy can also be done in this
Now,
patient.
what you will do? In your setup, what is the optimal treatment in this patient?
So that is what I'm asking you now. Tell me, in the current scenario, what are the indications of surgery in a patient with gastric outlet obstruction? Because you see, gastric outlet obstruction is a disease which is now very rarely treated by surgeons. So there are certain indications, because I myself have done a vagotomy, I think some 10, 20 years ago. If you ask me to do a vagotomy now, I cannot perform. Means I can perform, but then it won't be full. So there are certain indications for surgery in gastric outlet obstruction. So that is what sir is asking. And do you know any alternative methods of management which is done nowadays?
Sir, in case of if the apart from vagotomy, we can go for distal entrectomy if there are intractable peptic
No, we are
ulcers.
not talking of surgical treatment. You see, now there are a lot of good endoscopic procedures. Here, problem is what? Problem is you said there is unlikely to have active ulceration. Number one.
Yes.
Number two is you have a organic obstruction. So your
Deformed
idea is to
pylori.
relieve the obstruction, and your idea is to reduce acid secretion to prevent further ulceration.
Yes, sir.
Any other ways to treat apart from surgical treatment? Surgery is there. Patient come to surgical do surgical treatment. I agree, because the facility is not available in all the places. But if you have the facility, what else can be done short of a major surgical intervention? You see, there are a lot of endoscopies now who can dilate this first part of duodenum.
No, I think they should know about this endoscopic management, because nowadays when I go to other places for gastric outlet obstruction, they are asking about these endoscopes. Means what is the optimum size as to where you can do an endoscopic, what are the indications of dilatation, how much dilatation do we do, what is the regular interval, up to how much dilatation we can do, what are the complications of dilatation. Now, this is dilatation. Apart from dilatation, even they do a bypass. Okay, so PEG, or they do an endoscopic pancreatojejunostomia, gastrojejunostomia. So that is also what they are doing. So endoscopic management is definitely one aspect which you should know. And you know, surgery comes only nowadays. The indications of surgery comes only when the endoscopic management has been.
So I think, Anuradha, your answer should be guarded because you are in a surgical ward and patient is surgical department. you should still start your answer like this, that, sir, if these patients come with the complications, so I will assess, resuscitate the patient, and then I will discuss with the gastroenterologist whether he can be managed with non-operative means. That means this facility has to be there in your setup. If you don't have the facility, definitely surgery is the next mode of treatment. So if the facility for endoscopy is there and there is interventional endoscopy procedure available, now there are some options to offer these patient non-operative measures. Like you can do a balloon dilatation of the pylorus, followed by a PPI therapy. You have to keep them in PPI because underlying cause is not corrected. If the patient is H. pylori positive, you have to treat the patient with anti-H. pylori treatment. Okay. So if the endoscopic facility is not available, then you said you did truncal vagotomy and gastrojejunostomy. What do you mean by truncal vagotomy?
The anterior and posterior vagal trunks, before they are giving the hepatic and celiac ganglion branches, they are dissected at
Not
the level of
dissected.
the
They are transected.
transected at the level of the gastroesophageal junction.
You know what is criminal nerve of Gastric?
Yes,
What is
from
that?
the posterior vagal trunk, there is a vagal. There's a nerve which supplies the fundus of the stomach, the parietal cells of the fundus of the stomach. So, which even after dissection of the nerves of Latarjet, if we are not transecting that nerve, then that might lead to recurrent ulcers.
No. You don't separately transect the nerve of Latarjet. If you are doing a truncal vagotomy, you transect the anterior and posterior vagus
Yes.
higher up, and you should also keep in mind that you should divide all the nerve branches to the distal 5 centimeter of esophagus, abdominal part of the esophagus. That has to be sacrificed because here may be the nerve of criminal nerve of Gastric. So while doing that, you have to bear the esophagus, abdominal part of the esophagus, dividing all the branches. You said highly selective vagotomy. What does it mean? And
Highly
what is the
selective
advantage?
vagotomy is where the crowfeet branches of the nerves of Latarjet, which is supplying directly to the musculature of the stomach, those to the parietal cells, those
No.
are only transected.
Yes,
Only
the
the
nerve branches
crowfeet
to
branches
the body and fundus is transected, keeping
not the
the nerve of
pylorus.
Latarjet, which is supplying the
7
antral
centimeter
area,
of the
antral area, which is about 7 centimeter area from the pylorus. So that is the part of the nerve you keep. What is the advantage? What is the advantage of?
the pyloric motility is preserved.
And you don't need to do a.
Drainage procedure.
What is the disadvantage?
The disadvantage is that it might lead to recurrence, and
one is technically difficult. Need an expertise person to do a highly selective vagotomy. So it can be a technically difficult procedure, and there is higher risk of recurrence of the ulcer.
Because the antrum contains most of the gastric glands. So sometimes, so apart from the vagotomy also, sometimes we do anthrectomy also, right? Now, what are the different drainage procedures you know?
Gastrojejunostomy, pyloroplasty, then.
How would you like to do a gastrojejunostomy? Tell me something about that gastrojejunostomy that you do.
Gastrojejunostomy, Roux-en-Y gastrojejunostomy is better than loop gastrojejunostomy.
I'm not asking you which is better. Tell me which one will you prefer?
Roux-en-Y gastrojejunostomy.
So when we do a Roux-en-Y gastrojejunostomy every time we do a vagotomy and drainage procedure? When do we do a Roux-en-Y?
Usually in case of
when we divide the stomach, otherwise we don't do it. When we do an anthrectomy, then
yes,
we do a Roux-en-Y, right? But in other cases, we do a loop gastrojejunostomy.
Actually, Dr. Dey, that is our practice. What we do is in a loop gastrojejunostomy, the incidence of bile reflux gastritis is higher. So we have changed our practice of doing a Roux-en-Y GJ for even for a benign disease, because that is appears to be a surgery actually less of bile reflux gastritis.
Okay, if there is high reflux, Anuradha, can you tell me, sir told about bile reflux. Can you do any additional procedure to reduce that?
If you are doing a loop.
Loop?
Mm,
This is what we do already. We do it to prevent it.
mm. If the gastrojejunostomy is posterior and
No. You have done a
retrocoli-
loop gastrostomy. To
okay.
prevent bile reflux, you can do a jejunostomy.
That is
Yes, sir. Yes, sir.
So
Okay.
if you do that, then bile reflux is.
Yeah. So to avoid that, we often prefer to do a Roux-en-Y gastrostomy. If the patient has got a H. pylori infection, how will you treat H. pylori infection, Anuradha?
We have to give anti-H. pylori kit, which comprises of clarithromycin, various regimens. One of the regimen being clarithromycin, omeprazole, and metronidazole. And sometimes 4-drug regimen along with bismuth salts can also be given. Apart from omeprazole, we can prefer pantoprazole, which is much more effective. And replacing
Okay.
metronidazole.
Dr. De, we can conclude by
Yeah.
last 1 or 2 questions.
Means I don't have any questions now. Means I just want to say that yeah, it's important. Gastric outlet obstruction is definitely an important thing, but most of the management because I was given a class about endoscopic recent advances in endoscopy.
Yes, it is there for next month.
So I went through all the literature, and also now what I found out is these patients are basically managed by gastroenterologists nowadays. There is
Yeah.
scope for surgeons to manage. So I think that is very important because you should know about how much domain is left to us and how much domain is left to the endoscopy. Because if everything is taken out from us, then we won't be left with anything.
Yeah, that's the point. You should always keep in mind that patient is in the surgical long case examination means patient is admitted surgical what? Might be this was attempted or this facility is not available. So you have to keep in mind that the ideal answer should be non-operative management. If facility is not there or it has failed, then there is a question of doing a, because why surgery is not preferred, or Anuradha? Why surgery is going in the back seat?
So surgery causes more morbidity, and
Yes.
and apart from that,
You have
the
complications of vagotomy. You have
the
complications of gastrectomy.
yes,
Okay,
sir.
which can be a lifelong morbidity.
Yes, sir.
Okay.
Just
And
one.
the physiology and the anatomy is also deranged for following surgery. So that is also one of the reasons.
Now, before I end, just I want to add one word also more is that apart from gastric outlet obstruction, when you are presenting this case, you should also know something about the different types of gastroparesis, which usually occurs because that is, we are always concerned with mechanical obstruction, right? So based on that, means malignancies are more common. But also you need to give some information about gastroparesis, which is a non-mechanical obstruction and how it can overcome that problem. Okay, because that is a very common problem we also face in operations in the upper abdomen. So you need to know that also. Okay, otherwise, you have nicely presented, you have nicely answered. I think we could not complete the whole of the issue in such a short time, but that is what is usually done. And I think you presented well.
Okay.
Thank you, sir.
Develina from Clarinet. Thank you very much. We have a good session. The connectivity was good, but Anuradha has some audio issues from her own part, but I think otherwise it went well.
Thank you so much, sir, for the feedback. Thank you. So we are closing here.
Yeah, so we close, and our next class will be on Friday.
Right. Okay,
Friday,
sir.
same time.
We will get in touch.
So we have sent you the program. So
Okay.
you can just made a flyer for that and post.
Sure, sir. Sure. Okay. Thank you so much.
Thank you. Thank you very much.
Thank you.